Good morning and welcome to the February Epilepsy Seminar at GW. This morning I'm delighted to introduce Dr. MacKenzie Cervenka from Johns Hopkins. MacKenzie is an associate professor of neurology at Hopkins. She's the director of the Adult Epilepsy Diet Center and medical director of the Epilepsy Monitoring Unit at Hopkins. She earned her undergraduate degree and medical degree at University of Virginia and then came to Baltimore for her internal medicine internship and neurology residency at University of Maryland before she went to Hopkins for a 2-year epilepsy fellowship. She stayed on faculty at Hopkins since 2000, for 9 years now, 2010, and she is an associate professor. Her research has focused on the diet therapies for intractable epilepsy and for intractable status epilepticus. She has published widely and lectured worldwide on this subject. It's probably difficult to find a lot of publications on modified Atkins and other diet therapies recently without MacKenzie's contribution. She's also designed clinical trials for ketogenic diet and conducted studies to understand its mechanism of action. Please join me in welcoming Dr. Cervenka.
All right, well, thank you so much, Dr. Kavazi, for that wonderful introduction. Thank you for the opportunity to come here today. I'm very excited to talk to you all about the role of ketogenic diet therapies in the treatment of refractory epilepsy in adults, as well as status epilepticus. Here are some upcoming events. Here are the disclosures for the speakers and for myself. And so let's talk about some learning objectives. I hope that by the end of this session, we can all be able to identify adult patients with epilepsy who are appropriate candidates for ketogenic diet therapies, that we'll be able to talk about what those different therapies are and begin to think which therapies might be most appropriate for which patients. We'll talk about this both in the inpatient setting and in the outpatient setting, meaning in the outpatient setting, starting a patient with drug-resistant epilepsy, and in the inpatient setting, starting a patient who has refractory or super-refractory status epilepticus on a ketogenic diet therapy. And I want to be able to apply that knowledge to counsel adults, talk about side effects, talk about evidence for effectiveness, and pick out appropriate patients. So here is some more information about accreditation and CME credit and how to claim your CME credits, and you'll see some slides at the end about that as well. You all are familiar with the different treatment options for drug-resistant epilepsy. We start with anti-seizure medications. If anti-seizure medications fail to control seizures, we ask the question, does this patient have focal epilepsy? If they do, they could potentially be a candidate for epilepsy surgery, and we know that epilepsy surgery can be effective up to 70% in patients that have a focal lesion that can be resected. And then if a patient has generalized epilepsy, if a patient has focal epilepsy with multiple foci or an unresectable region, we have to think about other treatment options. That is when we start thinking of neurostimulation devices and of diet therapies as well. So when I talk about diet therapies, that's typically the point at which I start thinking about, would this be a reasonable option for a patient? We all know as well that once patients are drug resistant, so a patient has a first and second seizure, they are diagnosed with epilepsy, and the first medication you try works 50% of the time. If you try a second medication, it works around 10% of the time, and then the remaining patients tend to be drug resistant. Very few will respond to the third or fourth or fifth medication. And so the recent drug trials looking at drug resistant epilepsy have focused on comparing patients that have tried and failed 2 drugs. Instead of thinking primarily about seizure freedom, we think more about response rates. So when we talk about response rates, that is having a 50% or greater seizure reduction. And what has been really interesting about recent drug trials is that the placebo rate has been up to 20% in some of these studies. So in order to see an increase in response rate that's significant with a drug compared to placebo, you have to enroll many, many patients in these trials. And often what you see is that response rates are around 40%. Some recent drugs, they have been as high as 60%, and those are considered huge successes when we're talking about drug-resistant epilepsy. The seizure-free rate in these patients remains around 5 to 10%. These drugs have fewer side effects than the older medications, but unfortunately, we have not seen that they have higher rates of seizure freedom. So I'm just going over these statistics so that when we talk about diet therapies and efficacy, we can make a comparison to where we are with drug-resistant epilepsy treatments. So I'll go over the 5 ketogenic diets. I think Dr. Eric Kossoff was here a couple of years ago, and at that point there were 4, so we keep adding more and more ketogenic diets. Now you might notice I'm showing you 4, but I'll explain where the 5th one has come into the literature with regards to ketogenic diet therapies. Now on the side you'll see the standard American diet. So I'd like to talk about that for just a second before we move on. So the standard American diet is the bagel that you had this morning with the coffee with cream and sugar. And really the American diet is composed of greater than 50% carbohydrates. This is not the intended human diet. The intended human diet is something more similar to what we hear about with paleo. The intended human diet involves more fat, more protein, and fewer carbohydrates, but this has been the shift that we have seen over time, particularly with fast foods, with the 32 and 64 ounce sodas that you can purchase at various places. So let's move away from the standard American diet, regardless of what we talk about with regards to ketogenic diet therapies. I first want to talk about the term ketogenic. So where does that term come from? A ketogenic diet is a high-fat, low-carbohydrate diet. It is designed to cause a shift in the body's metabolism from using carbohydrate as the primary fuel source to using fat as a primary fuel source. Fatty acids are broken down in the liver, and they are broken down into what are called ketone bodies, and that's where the term comes from. So beta-hydroxybutyrate can be measured in the blood, acetoacetate can be measured in the urine, and acetone can be measured in the breath. Those enter the circulation again, and they all are known to readily cross the blood-brain barrier and can be used as an alternate fuel source. They're being used, you're burning fat, but what you can do is by reducing carbohydrate, you can shift and have this be the primary source of energy. This is my most ridiculous ketogenic diet picture. If you know me, I always talk about bacon. So bacon does have a lot of protein, but it also has a tremendous amount of fat. And so this is a pizza where the lattice is made of bacon, and then you throw on some cheese, a little bit of tomato sauce, because actually tomatoes do have a fair amount of carbohydrate, and a few mushrooms, those have carbohydrate as well. Most of the pictures won't be this ridiculous, but this is just as an example of what is called the classic ketogenic diet. Now, the classic ketogenic diet is the most extreme version. When I used to talk, and when I started giving lectures back in around 2008, 2010, I would mention the ketogenic diet and I would ask the question to the audience of adult neurologists, have you ever heard of this? No one raised their hand. Now the question is, how many of you have a family member, a friend, or someone who is claiming at least to be on a ketogenic diet? Anyone? Okay, that is more than half of the audience. So we'll talk about that as well, thinking about ketogenic diets in a broader sense, because this has gone beyond the treatment for epilepsy and this has become an absolute fad at this point. So we have to think about this in terms of just overall health benefits and risks. So where the idea of a modified diet, the 5th diet comes in, is that a classic ketogenic diet is 90% of calories from fat. What that means is that this diet is thought about in ratios, and that's the ratio of fat to carbohydrates and protein combined. And in the classic ratio, it is 90% fat. So I showed you the standard American diet. That was not healthy. This is also not a healthy diet. This was not designed to be a healthy diet. This diet is used for primarily children with very refractory seizures, and there are potential for side effects that we will talk about. There are things you need to do in order for this to be a relatively healthy diet. And then the modified versions are lower ratios, meaning a 1-to-1 or a 2-to-1 ratio. all of the foods are weighed on a gram scale. So if someone says, I'm using a ketogenic diet, and you ask them, oh, you're weighing your foods, and they say, no, it's not a classic version of a ketogenic diet, and I'll talk about what some other versions are, but these diets, you measure fat, carbohydrates, and protein in grams and calculate out what your ratio is based on a physician's recommendation. The other thing about a classic diet, and the thing I worry about having this be a very popular diet in the general population, is that I don't believe that everyone is using all of the supplements that are required in order to prevent side effects. So patients on a classic diet should be on a multivitamin, calcium, vitamin D, potassium citrate, which actually alkalinizes the urine and prevents kidney stones, because on the classic diet we know about 10% of patients have kidney stones, and actually I have seen this on patients that are using this for weight loss and not for epilepsy because they're not using potassium citrate. And then particularly in patients with epilepsy that are on Depakote, Depakote can cause carnitine deficiencies. This can happen with ketogenic diets as well, so there are instances, not always, where we may place patients on carnitine supplements, and we need to know that information as well. Pediatric patients historically have been admitted to the hospital to start the classic diet. Part of that is because they can become acidotic, so ketone bodies are an acid, and so they can actually lower the pH in the blood, and patients can become very lethargic. They can start having nausea and vomiting. You can also become acutely hypoglycemic because your body has not shifted to using fat as the primary fuel source, and symptomatic, and so those things are monitored. Initially, it was thought that starting the diet with a fast would actually kickstart the diet or result in better control of seizures. It does result in faster control of seizures, but long term, you don't see a difference in the outcomes of patients that are fasted before the diet or not. So when it's considered as an outpatient treatment and a patient is going to be starting it without hospital supervision, often they will do that without a fast. So there are centers that do a classic ketogenic diet, but they do it without fasting. Now, patients that are tube fed, this is something to consider. So you have these patients that come to see you that are adults that have intellectual disability and a feeding tube and very severe seizures. It is very easy to change their feeding regimen so that they're getting a ketogenic diet. You do have to go through their medications. You do have to make sure that there aren't extra carbohydrate sources that are coming from their medications that are significant, but it is actually very easy to use the diet in tube-fed patients. And most of the commercial products are what are called nutritionally complete, meaning that they have multivitamins, they have calcium, they have vitamin D, and so you don't have to think about that component of it. You can start the feed. What I would ask is that if a patient comes to you, because this is the other thing that's happening, is that patients will come to your clinic and they'll say, I started a ketogenic diet as part of my epilepsy treatment. It's working great, but I'm not exactly sure what I'm doing. Doctor, what should I do? So we'll talk a little bit about initial steps. Definitely refer them to an adult diet center if you don't have a dietitian that is working with you that's familiar with the ketogenic diet. If you do, there are some basic things to just make sure they're doing properly. The major thing, if the patient isn't going to be seen right away, make sure that they're taking multivitamin, calcium, and vitamin D, regardless of which of these diets they're on. So I've talked about the classic diet. Now I'm going to move on to the modified Atkins diet. So this was developed in 2003 at Johns Hopkins by Dr. Kossoff, and this is the primary diet that we use for adults. And I'll talk to you about the differences between the classic diet. I think in a lot of cases, people that are using diet for weight loss are doing something more similar to a modified Atkins diet than a classic diet if they're not weighing their foods on a gram scale. So typically what is prescribed is a limit on daily carbohydrate intake. In children, it's typically 10 grams of net carbohydrates, meaning that fiber, when you're looking at the label, fiber doesn't count. Fiber is what we call free, and so you can subtract that from the total carb amount, and then you can eat a limit on the carbohydrate per day. And in adults, that's typically 20 grams of net carbohydrates. We don't prescribe an amount of fat, so patients aren't weighing the food on a gram scale. We say eat fat liberally and then use ketone test strips or blood ketone levels to monitor your diet to see if you're eating enough fat. So you're getting feedback right away as to whether or not you're eating enough fat for your body composition, for your level of exercise, because we have patients who are vegan marathon runners. We have patients who are completely sedentary, and so what we do is we let their body respond and tell us whether or not they're eating enough fat, and then if we can look at their ketone values and know how we need to make adjustments. We use urine ketone values, and we usually use what we call moderate on the test strips, and you can see the test strip in the bottom corner. That is basically you pee on the stick. If it turns purple, you're doing a great job. And we are very positive. We motivate patients. We say, this is terrific, you're doing a great job. And if their ketones aren't turning purple, then we look at food records. We figure out how to increase their fat intake in order to get them there. And we use that as just a biomarker, because once they're in ketosis, then we can have the expectation that if we're going to see a seizure reduction, we should see it then. There are centers that use blood ketone measures, and what you can do, it's like a glucometer, but you do have to do finger sticks. There are lancets that you have to purchase. They're more expensive, and obviously it's more invasive. So if you have a patient that you want to use the least invasive version of the diet, we tend to use urine ketone values instead, and that's our thinking. But there are some centers that strictly use blood ketone measures in order to follow patients. And then hydration is extremely important. So when I talk about side effects, I'll talk about the side effects that can be avoided by drinking plenty of fluids. This is to give you an idea when I talk about 20 grams of net carbohydrates. So in a whole day, you could pick 2 things off of the McDonald's Happy Meal menu. This is the Happy Meal. This isn't the Big Mac. The Big Mac, you're toast. You can throw away the bun and you're still in trouble. So you could eat part of a banana. This dinner roll has to be about this big for it to be 14 grams of carbs. You could eat half of a Snickers bar or half of a can of Coke. There is nothing you can't have, but there are some things that are kind of silly to have. Half a can of Coke, are you going to really use half a can of Coke as your entire day of carbohydrates? Probably not. So when patients ask me, oh my gosh, I can't have this thing anymore, I say, well, you can, but you have to have a smaller amount and you have to budget your day. If you want to eat high-fat foods without carbohydrates for breakfast and lunch and you want to have a few French fries for dinner, that's okay. Now the question is, there are some centers also that try to separate out the carbs throughout the day, so there may be some very sensitive patients that eat a few French fries and get themselves into trouble. If we see that, then we can modify their diet further. So this is a comparison between modified Atkins and ketogenic diet, and you can see there is more protein, and this is why we call it modified Atkins. In Atkins, they just say limit your carbohydrates during the initiation phase, and then you can gradually go up on them. Fat and protein are great. Here, the goal is to get into ketosis, and you need about 70% fat in order to do that. There's another diet called the low glycemic index treatment. This is used primarily in children, but there are some adult centers that use it as well. This diet can be ketogenic. It is not always. The idea behind this diet is that patients with epilepsy, if they have a sudden spike in glucose levels, this can trigger more seizures. And so the idea is that you're choosing certain carbohydrates that are lower in a glycemic index, meaning when you eat the food, you don't have this high spike in glucose levels initially. So things that have a high glycemic index of 100 are things like white bread and soda. Things that have a low glycemic index are foods like hummus. And then you have a limit on the total carbohydrates per day. So what you have to do, instead of measuring foods, you have a list of foods and what their glycemic indexes are, and you have to go back and pick the foods that have the lower index. For us, we find this diet to be a little more complex than a modified Atkins diet, so that is why we start with modified Atkins. We have had patients that just wanted to eat a little bit more carbohydrate than what they were eating with modified Atkins, and that's when we might consider a low glycemic index treatment. And here's a comparison where you can see it's similar in the fat amount, more carbohydrates and slightly less protein compared to modified Atkins, but certainly more protein and more carbohydrate compared to a classic ketogenic diet. There is also something called a medium chain triglyceride diet. This was introduced in the 1970s and came and went very quickly. The reason for that is because you drink 30 to 60% of your calories from drinking oil, either coconut or palm kernel oil. This is what the bottle looks like, and not surprisingly, patients had very severe nausea, diarrhea, cramping, and so what you can do instead is you can slowly incorporate MCT oil into a ketogenic diet, and patients tolerate that better. Patients can still get up to a 30 to 60% of calories from MCT oil, but this is something that's titrated over a long period of time for them to be able to tolerate it. It could also be used in instances where patients have severe constipation because it can actually help alleviate the constipation. And so we use it typically as a ketogenic diet treatment supplement rather than as the primary fuel source with the ketogenic diet. The advantage is because it's pure oil, you can actually eat larger amounts of carbohydrate, and you can use the MCT oil and still stay in ketosis. But again, you have to really work up to this diet. You can't just start with it and expect to have a good outcome. So a few years ago, this was a slide that I showed when I lectured about ketogenic diet therapies. We had gone from 1984 with the frowny face with the bacon and eggs, and knowing that cholesterol was what caused diabetes and heart disease. And actually what we found out was no, it is the combination of high carbohydrates with a high fat meal that is causing these problems. And then we made this major shift to talking about fat is wonderful, fat is great, but we still have to send out the message that if you eat the fat in combination with a high carbohydrate diet, that is the worst of all possible scenarios. Then you will see those issues that have been discussed because your body is going to use the carbohydrate as the primary fuel source and not shift to using the fat as the primary fuel source, so the fat stays in your body and stays in your blood. So now we sort of understand more about that. And then there's the keto craze. So this is what I alluded to. I thought I had come up with the term keto craze. I absolutely didn't. It's all over the internet. This has happened in the last 2 years. And in fact, it was interesting. I heard on NPR recently that one of the few books, like the actual physical books that you hold in your hand, that is increasing in popularity as opposed to decreasing are cookbooks. And what is driving that is actually ketogenic diet cookbooks. And so this has become an absolute fad, and my concern again is you can do this diet, you can do it safely, but you need to have the supplements and the proper monitoring. This is Cosmo, and this is Women's World. There are all kinds of things out there. I have not read the article on Shortcut Keto. I don't know what that is, but I am very concerned about some of the things that are currently available out for the public to use. So I was asked last night at dinner what the mechanism of action of the ketogenic diet is. When I get asked that question, I usually say yes, because there are about 16 in the literature that have been proposed. We know that the ketogenic diet stimulates energy metabolism, upregulates hippocampal genes, stimulates mitochondrial biogenesis, inhibits glutamate-mediated toxicity, enhances GABA synthesis, decreases free radical production, and it inhibits the mTOR pathway. And we know the mTOR pathway is involved with tuberous sclerosis. We know the diet is actually very effective for tuberous sclerosis. So when you're asked about these mechanisms, there are many, many mechanisms that have been studied in animals and in humans. Interestingly, another really important mechanism, and we don't understand whether this is all related to the actual ketone bodies, if some of it is related to the reduction in carbohydrate intake, but we find that there's a reduction in pain related to thermal nociception in an animal model, and in several different models of either neurologic diseases or epilepsy, there's actually a reduction in pro-inflammatory cytokines. There was a beautiful study that was done recently looking at beta-hydroxybutyrate, one of the ketone bodies, and it directly blocks the NLRP3 inflammasome and directly decreases the secretion of IL-1 beta and IL-18, which are both pro-inflammatory cytokines. So we know that the ketone bodies themselves can be involved, but there are other mechanisms by which the diet is anti-inflammatory. And this becomes very important when we're thinking about the diet for refractory and super refractory status epilepticus, particularly in our NORSE patients where we suspect an underlying inflammatory condition, but we don't know what that is. This is one of the most recent studies that came out in 2018 that the diet also impacts the gut microbiome. So This is a very popular topic, the gut-brain axis, and how changes in the gut flora can alter brain metabolism. And so there were 2 mouse models of intractable epilepsy where they looked at this, and they saw 2 populations of bacteria that in particular increased on a ketogenic diet that are known to reduce GABA-glutamated amino acids and elevate the inhibitory versus the excitatory neurotransmitters in the brain. So we know that this occurs. We know there is an increase in these particular species of bacteria. And what's interesting is that if mice are reared on antibiotics or in a germ-free environment where they have no microbiome with these typical bacteria, then they do not respond to the ketogenic diet in these refractory epilepsy models. So they approach this from a couple of different angles. Now, other studies have jumped on and tried to reproduce this. It's still a work in progress. We haven't seen a lot more studies come out looking at this, but this is one potential mechanism. I don't know whether this can't happen immediately after starting the diet, and in some patients we do see benefit almost immediately, so obviously those other mechanisms are likely playing a part as well. So let's talk specifically about ketogenic diet for adults. The ketogenic diet was first introduced in the literature in 1921. Everyone thinks that it was initially just for children, and that's complete nonsense. So in 1928 and 1930, there were publications that came out in the United States about using ketogenic diet therapies for adults. In this initial study in 1930 of 100 adults, they actually found that 56% derived benefit. We didn't use that response rate metric back then, and so we just know those patients benefited from a ketogenic diet therapy, which is very similar to what you see in the literature in children now. This is a consensus that came out just this past year that was an update of a prior consensus for pediatric epilepsy. And what I will point out about adults is that everything in red here, these are patients that you will see in your clinic. One of the very interesting groups of patients are patients with glucose transporter protein 1 deficiency. These are patients who cannot transport glucose into their brain, and so they need a different fuel source. There is some debate about what that fuel source needs to be, but it can't be glucose because they cannot transport glucose into the brain. And so the primary treatment for this condition is actually the ketogenic diet, and often it can be monotherapy for these patients. And I have seen tremendous responses in patients, even adults that were not diagnosed as children, in which their cognition improves, their seizures improve, and as adults they often can develop movement disorders, and those can improve as well on ketogenic diet therapies. So those patients, if you see one in clinic, you should think right away about the ketogenic diet if someone has not started the patient on it already. These are also patients you're going to be seeing in your adult clinic because this entity, this genetic disorder, was discovered in the 1990s, and guess what? All of the initial patients that were diagnosed are now adults. And so these are patients we're going to be seeing in our clinic with refractory epilepsy and that are going to be on these diet therapies. I've mentioned formula-fed, so we have formula-fed adults that have refractory epilepsy. We should consider diet for them. I will be talking at the end about refractory and super-refractory status epilepticus. I've mentioned tuberous sclerosis. The diet has shown moderate benefit for cortical malformations. We have seen in our clinic juvenile myoclonic epilepsy that patients very much benefit from the diet if other treatments have not succeeded, because we know with JME often you very much can pick the first drug and the patient is seizure-free and it's never a problem again. I suspect these patients have particular genetic mutations that make them more refractory and that they're not classic juvenile myoclonic epilepsy, but what we have seen with these patients is that they benefit tremendously from ketogenic diet therapies, also Lennox-Gastaut and Rett syndrome. So these are patients we're going to be seeing in our clinic as well. In pediatric epilepsy, as I mentioned, the responder rate, so the chances of having a 50% or greater seizure reduction in all comers, is typically around 50%. So we're going to compare that to adults. And so there's always been the argument made that this could be a little bit better than trying the third or fourth or fifth drug. So that is where a lot of people place the diet in their treatment algorithm. The caveat to that is if a patient is a surgical candidate, please, 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 please do that evaluation first. you can talk about the diet if they absolutely refuse surgery, but surgery should be in that algorithm the first consideration because the chances of being seizure-free are much higher than what they are with diet therapy. So most adults aren't just big kids, but I know plenty that are. So important things when we're thinking about diet therapies for adults that are a little bit different than children. So food choices, checking ketones, and monitoring seizures. In kids, often the parents do these things. Often the kid just gets handed the food that they're eating. In adults, now sometimes adults do have spouses that can hand them the foods, and they actually do very well if they're not expected to prepare the foods themselves and the food is just given to them. But compliance can be a challenge for some patients. Of course, everyone wants to be seizure-free. One of the major motivators that we see is driving. So being a patient that responds to the diet is great, but you actually want to be seizure-free just like with everything else because then you can drive. And then we know other issues that come up as patients are transitioning from the pediatric to the adult world. Another major challenge is college and dining halls. So as I said, for instance, JME, those patients do very well with the diet. Then those patients go off to college, then those patients drink, they stay up all night, and then they have to deal with dining halls and trying to select the appropriate foods in that setting. So there are a lot of challenges that go along with these transitions that we have to think about with regards to the diet. And I'll touch on family planning in a few slides as well. So what do we know about adolescents and adults with ketogenic diets? These are some of the early studies that were looking at the largest studies that included adolescents and adults, and this is a review. 49% of patients were responders, and 13% were seizure-free. And these were not comparison studies. These were not clinical trials. This was just looking at all comers and looking at what the response rate was. This was an initial study of the modified Atkins diet where 47% were responders at 3 months, but I will also highlight that only 33% were responders at 6 months, and we have found in our clinic, and this has been reproduced by many other studies, that about half of patients, half of adults will stop their ketogenic diet within 6 months of starting. We do intention to treat analyses because this is realistic. If a patient can't be on it, then it's not going to help with their seizures, so we have to take that into consideration. And so when I do diet training sessions in my modified Atkins diet clinic, I can look out at the audience and know about half of the patients will be successful at staying on the diet, half of the patients will stop. You would think it's only the patients that don't respond that stop. That's not necessarily the case. It always breaks my heart when someone who's seizure-free decides to stop, but the diets can be limiting, and it's typically before that 6-month time period that you see that. So this has been repeated multiple times in different studies. 33%, 28% responder rates. These are lower in adults than children, primarily because of this issue of compliance, and about 50% of the patients stopping within the first 6 months, and that's typically the time frame for a clinical trial. So this is what we found in our center, not very different than what we saw in those other studies. We looked at over 100 patients in the first 5 years that we had our center open that qualified as drug-resistant epilepsy. 36% were responders. What I'd point out, though, is 16% were seizure-free. So this was not a head-to-head study. This was open label, but 16% did become seizure-free, which you could argue could be a higher rate than with the next drug trial, but obviously this was not a comparison study, so we can't state that specifically. In the past few years, there have been several clinical trials that have used various kinds of placebos, either diets or standard of care, to compare to ketogenic diet therapies. The ones that you see on the left are in children, and the ones in red are adults. And so going over these studies, there were some positive studies and some negative studies. There was an Iranian Journal of Neurology study that did show a significant difference in response rate, 35.5%, so that number is fairly consistent, versus 0% in care as usual. And so that was a significant difference. There was another study of the modified Atkins diet that actually they did not find a difference in standard of care versus the diet when they looked at 12 weeks. And actually the responder rates were 8% versus 5%, which is very, very low. So they did not see a significant benefit. Dr. Tanya McDonald, who recently joined our faculty at Johns Hopkins, and I collaborated on a study trying to find a way to improve diet compliance in adults. And what we did was we used a modified Atkins diet in 2 groups of patients, and in one group we added a ketogenic formula supplement to the modified Atkins diet in the first month versus the second month of treatment. And interestingly, both groups of patients had a significant reduction in seizures. So those 2 groups weren't different with regards to seizure reduction, but we did find that the patients that received that formula supplement during the first month of the trial actually stayed on the diet for 6 months, were more likely, and this was statistically significant, to stay on the diet for 6 months. These are all of the potential side effects, or the most common, I should say. There are a few others that are very rare. The ones that are bolded are ones that I worry about particularly in adults, and particularly adults that may be using the diet for weight loss and not being monitored. We've talked about several of these, and obviously weight loss is a side effect, so that's why it is being used. Ketone bodies suppress appetite, so once you're in ketosis, you actually have appetite suppression as part of the diet, so you end up eating less food in general. But things like osteopenia, osteoporosis, particularly for your GLUT1 deficiency syndrome patients, for your JME patients who you know have to be on diet lifelong, if they are starting on a diet, you have to screen for these things, just like you do with the older anti-seizure drugs. This is just a case series that we published along with a group from the Netherlands. There were 2 patients that were on a ketogenic diet for epilepsy and became pregnant. One was on a ketogenic diet as monotherapy in the Netherlands. We had a patient who was on the modified Atkins diet. She was advanced maternal age and on high-dose lamotrigine. And in their case, their patient actually was on a classic diet throughout pregnancy and had a baby who was a normal infant who was developmentally normal. The patient that chose to be on a modified Atkins diet during pregnancy that had been from our clinic, we actually didn't recommend the diet at the time. The patient left our center and then contacted us again once she was already several months pregnant, and we tried to help with regards to increasing carbohydrates slightly, making sure she was on the right vitamin supplements. And these helical rim deformities that you see are similar to what we saw in the infant. These were cosmetic, they were fixed, but we really don't know whether this could be related to a ketogenic diet or not. We don't know. We don't know if it could be related to the other factors involved, with her pregnancy. The infant is intellectually normal and is developing normally. We published this a few years ago, and the infant is fine in that regard. So we just, at this point, don't know if there are any risks of teratogenicity. We do know that the diet crosses the placenta. We do know that, ketones cross the placenta and do go into breast milk as well. We did a recent study looking at lipid profiles and carotid intimal thickness in patients on a ketogenic diet therapy for a year or more compared to patients that were coming to our clinic to start ketogenic diet therapy for the first time. We had done a previous study just looking at overall cholesterol levels, total cholesterol, LDL, and what we found was there had been a significant increase in 3 to 6 months for adults on a ketogenic diet, and that decreased by a year. These were patients on a modified Atkins diet, and they returned to baseline at 1 year. So we were reassured that the diet wasn't going to cause hyperlipidemia. What we looked at here was a more sophisticated measure of LDL particle size. So the idea is that small particles are more atherogenic. They enter the blood vessel walls more readily, and they can have an increased risk of cardiovascular disease, even in patients with a normal overall LDL. And the bad news is we actually did see, even in comparing 20 patients, that there was an increase in these small LDL particles in the diet patients versus in control. So it is something to keep in mind. These aren't standard measures that we use to screen patients, but I would argue if you see someone whose LDL is rising rather than correcting who's on one of these diets, go ahead and perhaps look at these measures and see what the particle size is as well. The good news is that carotid intimal thickness, which is a measure of elasticity of the blood vessels, was not different in the 2 groups. And that had actually been something, the opposite had been seen in children, that within a year or 2 years of the diet, there was stiffening of the blood vessels. We did not see that, but now we are looking at this prospectively to confirm our findings. So lastly, I'll talk about ketogenic diet therapy for refractory and super refractory status epilepticus. Just as a reminder, when patients are diagnosed with refractory status epilepticus, which means the benzodiazepine at the appropriate dose, which we all know rarely happens out in the field, and then more benzodiazepine is added when patients enter the emergency room. So a benzodiazepine at appropriate dose and a second-line therapy such as phenytoin, such as Depakote, such as phenobarbital, fails to stop the seizures, and then the patient is diagnosed with refractory status epilepticus. A third of patients die, a third of patients survive but have neurologic deficits related to the status epilepticus, and a third of patients recover to baseline. Patients are defined as having super refractory status epilepticus when they are treated with general anesthesia for approximately 24 hours. That general anesthesia is withdrawn, and they are actually either still in status epilepticus, meaning that the general anesthesia never controlled it, or they go back into status epilepticus. And the rate of morbidity and mortality is even much higher in these patients that are super refractory status epilepticus cases. We have all had these patients in our intensive care unit. This is my slide of the kitchen sink. So we throw everything at these patients. There is no rhyme or reason in what order we do this. We've looked at this in our center, and whether we pick propofol, midazolam, ketamine, or some of the other things on this list is completely arbitrary at this point, and we have no evidence to guide what it is that we're supposed to do. We do know that particularly in drugs like ketamine, the earlier that you use it, the more likely it is to be effective, which is not surprising. Time is brain when we talk about refractory status epilepticus, just like stroke, but we don't always treat it that way. So moving to the general anesthetic quickly can help, and also considering some of these other therapies. This was 2011, and there had been 4 published papers on ketogenic diet therapies. I'll also, because I'm going to come back to this, mention allopregnanolone. This was a recent study that was done, the SAGE trial that was actually a randomized controlled trial to treat super refractory status epilepticus. The reason that it's important, it was a negative trial, but what we know is that the placebo response rate and the treatment response rate were close to 40% and were not different. But now we know what we would expect a placebo response rate to be for super refractory status epilepticus, and it's approximately 40%. This is the up-to-date list of studies that have been done looking at super refractory or refractory status epilepticus and the ketogenic diet. These are studies particularly looking at adult patients. This is the protocol that we use when we're treating super refractory status epilepticus. We do use a 4-to-1 ratio ketogenic liquid formula. There are a couple of commercial products that can be used for this. Initially we used half calories and advanced to full calories within the first 24 hours. We treat hypoglycemia at a little bit of a at a lower number than what you typically do in the intensive care unit. We closely monitor bicarbonate levels because, as I said, patients can become acidotic. And because they've already had that first 24-hour wean, we typically try to wait 72 hours before we wean the patient a second time, so we make sure that they are in metabolic ketosis. However, there are some instances where this is not feasible from just a medical standpoint because of other issues related to the anesthesia. So what we found was that in our series of 15 patients, all achieved metabolic ketosis in a median of 2 days. Out of the 15, 14 completed the protocol, and 73% of those had response to super refractory status epilepticus. So this has encouraged us to pursue this as a future clinical trial, because obviously the difference between 73 and 40% could potentially be significant if enough patients are enrolled in a study. There has been a more recent trial that was very interesting that was published. This was a retrospective review of 11 adults looking at the treatment with the ketogenic diet for refractory status epilepticus. So not at the time that they have failed a wean, but actually at the time that they're intubated and sedated and put into a medically induced coma. Again, time is brain, treat quickly, treat aggressively. They found that 91% achieved metabolic ketosis in a median of 1 day, and that after 24 hours, they removed the anesthetic, and that status resolved in 43%, exactly the same number as what we had found in our trial, but this is when you're treating earlier. So some things that we are looking at with regards to these super-refractory status patients, we're looking at whether the diet can reduce the anesthetic drug burden that the patient actually receives in order to suppress seizures. We're looking at the impact of the diet on inflammation, particularly in new onset refractory status, but also in all comers. And then we are designing a randomized double-blind phase 2 trial of the diet to prevent super-refractory status epilepticus, so starting early during refractory status epilepticus and following patients prospectively in a randomized fashion. So I hope I've convinced you that ketogenic diet therapies are feasible, safe, and effective for adults with intractable epilepsy if they are compliant, but compliance does remain the major challenge in adults, and long-term side effects are largely unknown, but the ones that we do know we really need to monitor for. And then therapies may reduce morbidity and mortality in refractory and super-refractory status epilepticus, and this is something that warrants further investigation based on the preliminary findings. So this is the group from our center, our Adult Epilepsy Diet Center. These are our multi-center collaborators for our phase 2 trial, and we're always looking for more. Undergraduate students, the neurocritical care team, and the other neurology and neuropsychology team that see our patients, and here are my funding sources, and I'm very thankful for those as well. So that is the end of the talk. I'm happy to take questions, and I should skip forward to the code also for CME, I believe. So I will show you that as well.
Thank you so much. We have a couple of quick questions before I turn the microphone to the room. For any additional questions. First, there's an arithmetic question. You mentioned the net carbs are the total minus the fiber.
Yes.
So does that, I mean, that means that both can be really high. Like the total carbs can be really, if somebody consumes a big amount of Metamucil, let's say, that gives them the opportunity to eat a real pizza.
That is not correct. So I have been asked, patients' eyes light up when I talk about that calculation. So the issue is it's the fiber within. So when you look at a food label, what you'll see is it says total carbohydrate, and underneath of that, it will say fiber, sugar, other carbs, and you can subtract from that total number, but if you take in Metamucil, that doesn't actually zero out the carbs such that you can eat more carbs, and it's going to take away from that. Does that make sense? So I have had patients that have asked me that. They've also asked, can I drink olive oil or something to boost my ketosis after I eat the pizza? We don't know that that necessarily works because you're still going to metabolize the pizza and you're going to not go into ketosis. In fact, that's probably worse than not doing that at all. The other question I get, and the thing I didn't touch on but is also very popular with these diets, and also in the community exercising, bodybuilding, are ketone esters. And so my epilepsy patients have asked me, can I eat a pizza and then take ketone esters and stay in ketosis? I worry about that because the ketone esters only boost ketone levels for a very short period of time, and then they crash again. And my worry with epilepsy patients is you really want them at a stable level of whatever treatment you're using. You don't want their ketone levels to go up and down rapidly. So that is another strategy that people have asked me about, but unfortunately, I wouldn't recommend any of those at this point.
Okay. And then you mentioned 16% seizure freedom in your trial. What was the follow-up duration, the mean follow-up duration?
So this was at 3 months. Yep. And again, we, like I said before, in our center, just like in other centers, patients will drop out of the diet within about 6 months if they're going to. Interestingly, if they don't drop out by 6 months, they tend to stay on the diet long term. So what we do in our center is that if a patient does become completely seizure-free, then we will talk to them at 2 years like you typically would about tapering off of anti-seizure medicine if their EEG is normal, if they don't have other factors where we think they're going to have lifelong epilepsy. And then once they're off of the anti-seizure medicines, we ask them whether they want to stop the diet as well. We never recommend going back to that American diet. In fact, I don't recommend that for anyone. But we usually will tell them go back to around 80 or 85 grams of net carbs. That is not scientifically proven, but we've actually seen some patients try to taper off the diet, which we do by increasing 5 grams of net carbs every few days, and they hit a limit. Some of them it's 30, some of them it's 50, where the seizures just come back aggressively and return to what their baseline was, so then they drop back to 20 and just stay at the diet. And this is off of medication, so it's their only therapy, and suddenly you see the seizures come back. We've seen that also in patients that come to the epilepsy monitoring unit. So they've had a seizure reduction, but not seizure freedom. And when they come into the monitoring unit, we let them eat a donut, and the seizures just come in a flurry. So we have seen instances where that's happened as well.
Regarding the anti-inflammatory mechanism of action, did that lead to any trials of the diet outside of epilepsy, connective tissue disorders?
Absolutely. So the diet, I didn't show my slide for this, but the diet is being looked at for just about everything you can think about now. So particularly like rheumatoid arthritis. We are doing a clinical trial with Alzheimer's disease and the modified Atkins diet, and we do think there is an inflammatory component to that we're treating. It is something we're looking at as well with these patients that are either randomized to a diet that is the kind of standard recommended diet for aging versus a modified Atkins diet, and we're looking at those patients to see if there are changes in inflammatory biomarkers during the course of being on these diets. We're also using it for glioblastoma, but the mechanism there is a little bit, the proposed mechanism there is a little bit different, but they are being used for other inflammatory conditions as well and looked at in terms of reduction in inflammation.
We're part of a multi-center trial of Tysabri for epilepsy.
Yes.
So maybe
we are as well.
Maybe we pay them back by the MS community by trying the ketogenic diet on the MS.
And it is being tried in MS as well.
Yeah.
Yep.
And then my last question is whether there have been any studies that looked at the behavioral comorbidities of epilepsy and whether they get ameliorated with the diet.
So absolutely, those trials are more looking in children, that they've been done more extensively because there are more children that have been treated with the ketogenic diets as compared to adults, and they've done neuropsychological assessments serially, and they've done surveys and things and found that there is overall cognitive improvement as well in patients on the diet. We know that anecdotally from our clinics that even before we start lowering anti-seizure medicines, patients will say to us, I'm able to think more clearly, I'm able to remember things better, I don't feel as tired. We hear that a lot in our patients, and we haven't quantified it yet, but I know other centers, adult centers, are looking at this specifically as well and trying to have metrics for quantifying this in their patients.
Excellent. Thank you so much. Any questions?
So how you feel about the ketogenic diet for the diabetes patient?
Excellent question. So there is a whole group of patients with type 1 diabetes that are using ketogenic diet for that. What we tend to do, because obviously we see patients with comorbid diabetes and epilepsy, we tend to use it, we do use it in type 2 diabetics. We let their endocrinologist know that we're going to be starting the diet because obviously if they're on any amount of insulin, that's going to need to be adjusted. If they're on metformin, if they're on another agent, those drugs may have to be taken away. And we've had a couple of type 1 diabetics that we've started on the diet, one in particular who had an insulin pump. And that way we knew they were going to be monitored closely, that have had just absolutely miraculous responses from the perspective of their diabetes and from the perspective of their seizures as well. So we don't shy away from it, but we do make sure that we're doing it in close discussion with their endocrinologist. Sometimes they'll have their own nutritionist as well, so our dietitian will reach out to them and work in coordination with them to modify what's being recommended for their diet.
You know, a couple of years ago you mentioned you were looking at catamenial epilepsy and diet. So Any comments on that?
Yes, so that study is still in progress. We are hoping to wrap up in this calendar year. So far we haven't looked officially at the data yet, but what we're doing is using an MCT supplement in combination with catamenial epilepsy. So we use the Herzog criteria for identifying a patient with catamenial epilepsy. What we found initially that I think I'd spoken on before was that when patients were started on a modified Atkins diet that were having, for instance, daily seizures, that the seizures were actually eliminated except in a catamenial pattern. So there is some interaction between ketone bodies, the diet, and their seizures that we have many surveys that we're still analyzing to figure out what that interaction is. But the idea for the clinical trial was to use this MCT supplement to boost ketosis in that period where we see that they're having the most seizures. And as I said, that is a work in progress that's almost done.
Thank you.
Thank you.